Hello, my name is Rita Brown and I'm the President of the Australian BPD Foundation. I'd like to take this opportunity to acknowledge the traditional owners of the lands on which we're meeting from today and pay my respect to their elders, past, present and emerging. So welcome to today's forum on the latest treatment developments in the treatment of BPD with Associate Professor Sathya Rao. We've got participants attending from around Australia today, so welcome to you all. The session will be recorded. Any concerns, please send me a text via the chat box. There will be an opportunity to ask some questions via the chat box throughout the session, and Sathya will answer as many of those as he can. I'd just like to now introduce you to Sathya Rao. Sathya is the Clinical Director of Spectrum, the Personality Disorder Service in Victoria. He is a pioneer within Australia in the treatment of BPD, and his passion for research, evidence-based practice and teaching has inspired hundreds of health professionals within Australia and abroad to specialise in this area too. His quiet determination to dedicate himself to working with people living with borderline personality disorder has saved lives and changed families forever. Last week, he received the Royal Australian and New Zealand College of Psychiatry Victorian Branch Meritorious Award in acknowledgement of his contribution over many years towards understanding and supporting patients with BPD and his immense contribution to clinical services, training, education and research. For those of you who attended this forum in person, I'd like to apologise that this recording is a little bit delayed in starting. I accidentally hit the stop button instead of the play button. So the first minute or so of his presentation was not recorded. And he spoke briefly about Spectrum, and I'll try and fill in for him. So Spectrum is a centre of clinical excellence for borderline personality disorder. It's a Victorian statewide service for personality disorders. It supports and works with local area mental health services and health professionals to provide treatment for people aged 16 to 64 who have a personality disorder, with the focus on those who are at risk from serious self-harm or suicide and have complex need. Spectrum is also involved in research and workforce development. The prevalence of personality disorders within the Australian community is approximately 6%. They tend to be high users of various services, both mental health, housing, forensic, justice. BPD is often associated with very high treatment costs, as people with BPD have got a higher risk of completing suicide. Spectrum did a study with the Victorian Coroner's Court, and 10% of all suicides in Victoria over a 5-year period were linked to having a personality disorder. And a study from Bringrinia from Project AIR in New South Wales highlighted that there's limited recognition of personality disorders as being a public health issue.
It's about 15 to 20%. In the emergency departments of the psychiatric presentations, about 10 to 15% of the presentations is for personality disorders. And within the primary care sector, again, it is a very, very common, 6% is the prevalence of personality disorders in the primary sector. Now, I just want to draw your attention to the fact that schizophrenia also has a prevalence rate of 1% in the community, and bipolar disorder again has a prevalence of 1% in the community. But imagine the amount of funds we provide for treatment of schizophrenia and bipolar disorder as compared to borderline personality disorder, although the prevalence rate is the same and the mortality and morbidity rates are the same. So that's by and large because BPD is still quite stigmatized and people don't understand the benefit of treating borderline personality disorder. Now, we have recently become aware in the last 5 years that if someone gets a diagnosis of borderline personality disorder, they can potentially have a 20-year reduction in their lifespan. This number is not contributed significantly by death by suicide. So this is because of all the medical and medical side effects, medical problems that can co-occur with borderline personality disorder, and the side effects of the enormous amount of medications that we unfortunately still prescribe, despite medications not having much of an evidence base. The suicide rate is 10%, although the recent studies are a bit more optimistic, and they show a suicide rate of about 5%, but still 10% is still the universally accepted suicide rate, unfortunately. Non-suicidal self-injury is extremely common in borderline personality disorder, and almost all the patients, up to 85% of patients, have non-suicidal self-injury. When I talk about non-suicidal self-injury, I mean the common ones are the superficial cutting behaviors, taking minor overdoses, or burning, or inflicting other harm to themselves. I'm assuming that most of you are quite familiar with the clinical features of borderline personality disorders, so I'm not going to spend too much of time. But just to highlight the fact that borderline personality disorder is characterized by instability. Instability is one word we want to remember and associate with borderline personality disorder. Instability of emotions, instability with respect to relationships, and self-identity. Borderline personality disorder is also associated with impulsivity, a chronic feeling of emptiness, fear of abandonment, a very significant symptom, quite characteristic of borderline personality disorder. Fear of abandonment in the context of interpersonal relationships, which become much more highlighted in the context of romantic relationships. Anger discontrol and micro psychotic episodes and dissociations. Some patients also experience the chronic sense of emptiness in such a deep way that they almost feel lacking in identity. A researcher by name Zenani has coined the term identitylessness. This is an important symptom because this can be associated with significant emotional pain for patients who have that symptom. Recurrent suicidal behaviors, gestures or threats, or self-mutilating behaviors is a diagnostic criteria for BPD itself. And as most of you know, chronic suicidality is a signature symptom of BPD. So the frequent self-harm and suicidal behaviors of BPD creates a significant amount of anxiety amongst treating clinicians, and often some clinicians fear working with the people with personality disorders because of this fact. So this is our cookbook, DSM, which lists the criteria for BPD. As you can see, there are 9 criteria listed, and you need only 5 out of the 9 to make a diagnosis of borderline personality disorder. And these are not weighted criteria, by which what I mean is that no one criteria is more important than the other. So what it means is that you can have very many types of people with borderline personality disorder if you mix and match this 9 criteria to get 5 to make a diagnosis. Now, suicidality in borderline personality disorder needs to be understood quite different to how we understand suicidality in other psychiatric disorders. Suicidality can be seen as a coping strategy by and large, and most don't go on to end their lives by suicide, and herein lies the paradox. Um, the only way for them to go on living is to maintain the option of dying, and people with borderline personality disorder can threaten to die in order to stay alive. So these are some of the statements made by an expert in BPD called Joe Paris, a Canadian expert, trying to describe the dilemma people with borderline personality disorder experience, and the dilemma reflected in the clinical workforce. So Joe Paris also wrote a book titled Off in Love with Death. So the point he makes is that the life feels so painful for people with borderline personality disorder that they are off in love with death. So again, that's the same point which I was making earlier on, that people with borderline personality disorder can often tolerate distress only if they know that they can escape it by suicide if all fails. Now, borderline personality disorder, as I told you, is a very highly stigmatized disorder. The person who coined the name borderline personality disorder, John Gunderson, unfortunately is no more. He makes the statement that BPD is to psychiatry what psychiatry is to medicine. There are several myths about borderline personality disorder. Let's see whether we can clarify and bust some of those myths. It is commonly believed that borderline personality disorder is a disorder that impacts women. However, we know that borderline personality disorder impacts both genders equally. So when you do a community prevalence study, the split between men and women is almost equal when it comes to BPD. However, in clinical teams, if you look at the prevalence in hospitals and community mental health systems, we see predominantly women turning up to clinics. That's because often men with borderline personality disorder land up in drug and alcohol services, and or even unfortunately in the justice criminal systems. So diagnosis of borderline personality disorder in men is still quite uncommon. So I think I made this point. The second myth is that borderline personality disorder can be diagnosed only after the age of 18. Although we know that people under the age of 18 can and do present with symptoms of borderline personality disorder, and often they're not given a diagnosis of BPD. They're given a diagnosis of emotional disorder or depression. And the problem with that is that it's not. We're not saying that you should just give a diagnosis of borderline personality disorder below the age of 18 just to give a label. What we are more concerned is that if you don't diagnose, you may not treat the disorder. And if appropriate treatments are not offered until the age of 18, they suffer. And after the age of 18, dramatically they're thrust into adult mental systems, and they're treated with. The attempts are made to treat with BPD specific treatments. Now, Andrew Channon, a pioneer in this field from Melbourne, he has published data that BPD emerges most commonly during adolescent period, and Mary Zanini has also published papers. You may be familiar that we have national guidelines for treatment of borderline personality disorder, the NHMRC Clinical Practice Guidelines, so which was published in 2012. Those guidelines clearly state that we can make a diagnosis of borderline personality disorder under the age of 18. So the recommendation is that after the age of 12, and most commonly post-pubertal age, we can make a diagnosis of borderline personality disorder if patients exhibit signs and symptoms of borderline personality disorder. Of course, when you're looking at treatment, we need to take into consideration the developmental aspect of that age group. And we need to tailor the treatments to that population. Another common myth is that borderline personality disorder usually manifests in early adulthood or adolescent years and disappears with age. We don't think of giving a diagnosis of borderline personality disorder for the first time if somebody presents at the age of 50, for example, or somebody presents for the first time at the age of 65 or 70. Now, just to confess, I never believed that borderline personality disorder existed beyond the age of 65 myself, until recently, when we did a survey amongst our aged psychiatry colleagues. What they told us was quite shocking. They said that at least 10% of their patients in the inpatient settings have borderline personality disorder, according to them. Now, what we know is that BPD can present across life stages from the age of 12 onwards, and certainly it is not uncommon in the old age group. There is also a group of patients belonging to the late manifestation group. I'll say a few words about that group. This is one of the papers we published on old age in BPD. So late manifestation of borderline personality disorder, there are a third of patients at spectrum who present for the first time around 40 or 50 years of age. When we go through their case histories, what we find is that they've had the usual BPD etiological risk factors during their childhood, such as trauma or attachment problems. And around the age of 16 or 18 or 20, they've had a couple of symptoms of borderline personality disorder. Either they've had some self-harm behaviors or had some eating disorder symptoms. Then they become asymptomatic. What we find in that patient group is that they've either had a very stable relationship or they've had a stable job. And that seems to have somehow contained the symptoms for them. And around the age of 40 or 50, if they've had a loss of relationship, which has held the symptoms, contained the symptom, or they've had a loss of their occupation, job, then they seem to have severe symptoms of borderline personality disorder. Usually a misdiagnosis of bipolar disorder, depression is made, and later on they refer to spectrum, and we give them the diagnosis of borderline personality disorder. And they do respond to treatment when we treat them with BPD-specific psychological treatments. The next common myth is that BPD is caused by childhood trauma alone, and that biological factors don't play a role. We know that 85% of people with borderline personality disorder report history of trauma, commonly childhood trauma, and up to 10% of people with BPD report no significant childhood traumatic experiences or attachment difficulties at all. And however, attachment problems are quite common in BPD. And we also need to think in terms of parent-child misattunement. Even if there is a good enough parenting done, if there is a misattunement between the child and the parent, that can lead to attachment difficulties and perhaps in some situations borderline personality disorder. So what's important to note in this slide is that 10% of people don't seem to report any childhood difficulties at all. No attachment problems, no trauma problems, still go on to develop borderline personality disorder. Now, what are the biological abnormalities that we see in BPD? We know that 50% of borderline personality disorder is heritable. So genetic contribution is 50%. So what is the 50% genetic contribution? It is usually an abnormal emotional system. What we call it as the corticolimbic system. You would know that the emotion part of the brain is called amygdala. In borderline personality disorder, amygdala is hyperactive. The emotion system is hyperactive. And normally what happens is that the emotional system is controlled by the thinking system, the thinking brain, the cortical brain, the emotional brain, the amygdala. So the thinking brain controls and regulates the emotional brain. In borderline personality disorder, we know that there is a poor control of the cortex, control of the amygdala by the cortex. So what we mean is that the emotional system is poorly regulated, poorly controlled by the thinking brain. We also know that because of brain abnormalities, the facial expressions are misperceived in borderline personality disorder. And also there is a part of the brain called the anterior insula. There seems to be some abnormalities in borderline personality disorder, which is related to producing cooperativeness in interpersonal behaviors. Now, so in summary, what it seems like is that borderline personality disorder is again caused by biopsychosocial factors, as it is with all the other psychiatric disorders, and environmental factors such as attachment difficulties, trauma, bullying may all contribute to development of BPD. So trauma is very common, and it is a very important and significant risk factor, but not essential, a prerequisite for development of BPD. What it means is that see, there's some very elegant studies that have been done where they've followed up children who have suffered trauma. Not all people who experience childhood trauma go on to develop borderline personality disorder. About 80% of them who have childhood trauma don't develop psychiatric disorders. 20% of them develop psychiatric disorders. Of the 20%, a range of psychiatric disorders can happen, and borderline personality disorder is just one of them. Now, this is the point I was trying to make earlier on, saying that the prefrontal cortex, the thinking brain, has less control over the emotional brain, the amygdala. There's a pictorial representation of that. And that can lead to a few problems. If you are to metaphorically think of, if we compare the emotional system of someone with a BPD to a car, I mean, no disrespect for my patients at all, then a person with BPD is driving a car with very, very sensitive accelerators and poor brakes. Sensitive accelerators meaning amygdala, the emotional brain. Poor brakes meaning the thinking brain, the cortex, which is offering poor regulation. So imagine someone driving that kind of a car, poor brakes and hypersensitive accelerators. No wonder they can run through the red lights and their driving can be seen erratic. But unfortunately, for someone who sees from outside, they're not going to be able to make out that this person has an abnormal brain system. Now, what is the task for clinicians? Demand for clinicians is to be an empathic driving instructor, sitting in that car and sharing the journey, which has got poor brakes and very, very sensitive accelerators. So that's why sometimes it can be challenging to work with people with borderline personality disorder. Now, of course, the driving instructor has their panel controls, admissions, medications, blah, blah, blah. But if that is used excessively, then we're not going to be able to help the person to learn to drive that car, which has got poor brakes and sensitive accelerators. What we know in science is that if the clinician is able to tolerate their own anxieties and help the patient tolerate their anxieties as well, then over a period of time, this person is able to learn how to drive that car. Despite the poor accelerators and the poor brakes, they're able to drive that car appropriately. And this seems to be a magical car because over a period of time, the brakes become better and the accelerators tend to be less sensitive. Of course, clinicians trained in treatment of borderline personality disorder who accept support and supervision do very well working with people who have borderline personality disorder. Now, so to summarize what I was saying, I'm going to use this phrase from the national guidelines. Having borderline personality disorder is not the person's own fault. It is a disorder of the brain and the mind. I believe this is a very crucial slide and a crucial statement for us to understand and accept, because that can create a significant shift in our thinking about people with borderline personality disorder. I also think that the actual treatment of borderline personality disorder, the psychological work, is really not rocket science. What often comes in the way is that because we don't tend to believe that these people are genuinely unwell and they have a genuine problem in the brain and the mind. If we don't believe that, then our treatment is going to be colored with our own biases, our own judgments, and that comes in the way of the work. So another statement that people with borderline personality disorder can be challenging to treat, but it is the illness that produces the behavior, not the person. Okay, now I'm going to shift slightly and change tracks and talk about an important study that we did at Spectrum. This is
Sathya?
Yep.
There's a couple of questions. Are you okay if I pose them to you now, or would you like to do that a bit later?
Go for it.
So one of the questions is around your comment about men being diagnosed more frequently. And do you find men with BPD often end up in AOD services and thus seek treatment for substance use and the BPD is overlooked?
Absolutely, absolutely. When they land up in drug and alcohol services, often BPD is not diagnosed. Even if it is diagnosed, it is not treated. And so the prevalence, as I was saying, it is 50-50 in the community. If you go door knocking, do a community prevalence study, it is 50-50.
Yeah, thank you. Then another question, can I please ask you from a medical professional perspective, should there be an expectation that ER doctors and community health staff should be aware of the national clinical guidelines for the management of BPD?
That's a brilliant question.
The person's not sure that the medical field sees these guidelines, so is interested in hearing your perspective.
Yeah, look, that's a very good question, and thank you for asking. You're absolutely right. We need to make sure that the entire medical profession, and particularly people in the emergency department, emergency physicians, should be educated about clinical practice guidelines. Rita, through the BPD Foundation, and ourselves through the clinical workforce, we have been lobbying with the federal government for years, asking the federal government to implement the national guidelines across the country so that all appropriate clinical workforce can be trained and educated. That's a huge gap right now. And I completely agree with that question.
The second part of that question, if we have any ideas how we can, maybe people may be able to influence them to get them known.
See, two ways of doing it. One is to join the Borderline Personality Disorder Foundation, because one person might not be able to change. A group of us certainly can influence and change things. So join the BPD Foundation, add your voice to the issue. That's one way of doing it. Second way of doing it is to go to your emergency department and try and make friends with the emergency staff and see whether we can organize some education program for them.
Thank you. Another question based around your comments around trauma and
Yep.
asking about a differential diagnosis between complex PTSD and BPD.
Yep.
And the different evidence-based treatment approaches. Will you be covering that later? Or
I'm happy to answer that question now. So the question is about the difference between complex PTSD and BPD. And what is the second part, Rita?
the different evidence-based treatment approaches.
Okay. Look, see in DSM-5, we still can't give a diagnosis of complex PTSD. However, in ICD-11, which is the latest version of the ICD, you can either make a diagnosis of complex PTSD or make a diagnosis of borderline personality disorder. There are two different diagnoses in ICD-11. Now, as of now, the requirement to make a diagnosis of complex PTSD in ICD-11 is quite stringent. Someone needs to have had very, very severe trauma, such as torture, being kidnapped, and those sort of very, very severe kind of trauma. Now, some of the symptoms, some of the clinical features described for complex PTSD in ICD-11 and the clinical features of personality disorder, there's a huge overlap. So very early days, very limited research has happened. And even this question about the significance of trauma, we know that trauma is absolutely a risk factor. The current thinking is that it may not be etiologically linked. Look, the last word has not been said. I myself, so my experience working at Spectrum is that almost every patient of ours has experienced trauma. And if we can't work with trauma, we really can't work with people with borderline personality disorder. So now, does trauma influence the way the symptomatology of borderline personality disorder and the psychological profile of people with borderline personality disorder? It seems to be very, very significant. So, see, the last word has not been said. So, I'm just stating the current science. The current science is that trauma is a significant risk factor, but not absolutely essential to make a diagnosis. So, the treatment of now, some more confusing information. Now, borderline personality disorder, you know that dialectical behavior therapy is one of the most common treatments. Now, DBT has developed newer treatment approaches called DBT T for trauma, or DBT PTSD. So DBT protocols for treatment of trauma right from the word go, not in stage 2, from stage 1 itself. So what's happening is that in the field, people are becoming aware that we need to be able to treat trauma, address trauma, side by side when we are addressing other features of borderline personality disorder. Now, can DBT trauma be provided for people with the complex PTSD? It feels like we can. So there is very little research evidence right now to say anything categorically. Now, if you have a patient in front of you who has had significant childhood trauma and has signs and symptoms of borderline personality disorder, now as a clinician, you are going to be confused as to whether you should give a diagnosis of complex PTSD or give a diagnosis of borderline personality disorder if you were to use ICD-11. Okay, so the last word has not been said. What is likely to happen is people who are persuaded more by trauma etiology are likely to give a diagnosis of complex PTSD. People who are going to be more persuaded by BPD literature are going to give a diagnosis of BPD, borderline personality disorder. Also, Uh, my experience is that people with borderline personality disorder who experience trauma often feel comforted with the name complex PTSD rather than with the name borderline personality disorder because of all the stigma that it carries. I mean, the name itself is quite hopeless. So, I think. What is borderline? What is if you call somebody as a borderline personality disorder, you're almost saying that there's a flaw in the character of the person or the being of the person, and that it is not even a proper flaw; it is a borderline flaw. So it doesn't make any sense. So of course, there were historical reasons why we came up with that name. We need to be able to get rid of the name and come up with something different. So that's a very long answer. So what I'm trying to say is that there's a lot of confusion in the field. So, but if you have a patient with trauma, please work with trauma as well as with personality disorder. Thank you, Rita. Hi, Rita, are you there? Rita, can you hear me?
I can hear you. I was muted. But there's a couple of other questions coming through, but we might let you finish the key part of your presentation and put those questions later.
Yeah. If you want, I can answer them now.
Okay. So if there's anything known about the relationship between men who have BPD and perpetrate family violence, and working with this specific cohort in relation to differentiate between accountability for their use of family violence and addressing BPD.
We know very little about men with borderline personality disorder. There is very scanty literature, and there are a couple of randomized control trials. I think they have tried both mentalization-based treatment as well as dialectical behavior therapy and some common factors, but very, very scanty literature. So, in fact, if you look at the last 25, 30 years of science that we have about borderline personality disorder, almost all the science that we have has been developed based on our research on women with borderline personality disorder. Whether it would apply, the same would apply to men or not, we have very little information. Having said that, in the last 4 to 5 years, there's lots of research being done. You will see in the next 5 years lots of publications about men with borderline personality disorder. So that's one aspect. So we don't even know completely. We're not absolutely confident whether the treatments that we do for women would also work for men or not. But we all do. We need to continue to do so until we have more evidence. Now, the relationship between domestic violence and borderline personality disorder or personality disorders in general, there is a little bit of literature, but not a whole lot.
Right. Okay. And just one more question. What biomarkers are there to indicate BPD is an illness? And is there really no other way to envisage it without becoming uncompassionate and judgmental? After all, if someone hasn't learned how to walk properly, we don't see it as an illness, but still we don't approach it judgmentally.
Yeah, see, this is again an area for us to understand more and research more. So that really cuts to the very question, is borderline personality disorder a psychiatric disorder or not? Isn't it? Now, there are arguments for both sides. Now, one argument which I am persuaded by is that if we say, let's say if we take a stance that borderline personality disorder is not a psychiatric illness, okay, then the implication is that then the hospital systems will have less to do with borderline personality disorder. Emergency department will have less to do with borderline personality disorder. Now, psychologists, psychiatrists, social workers, occupational therapists, all the allied health, mental health workforce will have less to do with that. That's my fear. Now we have. So, will the support and the treatment that is offered to people with borderline personality disorder would be further reduced, and the mental health workforce would be further confused? So that's another argument. That's the argument I'm a little more persuaded by. Now, if the question is borderline personality disorder a personality disorder? Is it just some psychological disorder? So that's the part which I believe we'll have more clarity in the next 10 years or so. Also, the biological problems, biological abnormalities that we find in borderline personality disorder, which is again the chicken and the egg story. Whether it is because people, since from childhood onwards, people have attachment difficulties and trauma and other difficulties. Is that because of that the brain abnormalities are developed, or because they have brain abnormalities, they develop the symptoms? That is still unknown. What seems to be a lot more clearer is that there seems to be some genetic contribution. That doesn't mean to say that just because someone has a borderline personality disorder, so their offsprings will develop borderline personality disorder. No, that's not what it is. What it means is that they might carry the vulnerability to develop an emotional system that, superimposed with environmental factors, can contribute to development of borderline personality disorder. Without the contribution of the environmental problems, even though they may have the genetic vulnerability, they may not have any problems at all. They may not develop any psychiatric problem.
Okay, well, thanks, Sathya. We'll hand over back to you.
Thanks, Rita. Now, I was going to talk to you about a coronial study that we did. So what we did was we liaised with the Coronial Prevention Unit of Victoria, and we had access to their database, and we looked at all the suicides related to personality disorders for a 5-year period in the state of Victoria. And what we found were, I'll just give you some highlights. We found that 10% of all suicides for all reasons was for a diagnosis of personality disorders, and almost all of them had borderline personality disorder. So it's a very significant number. So my question is, so we have this National Suicide Prevention Initiative. Now, do we put in 10% of all the national efforts for suicide prevention into borderline personality disorder? I don't believe so. So some more very important findings were 99% of those patients who passed through, who died by suicide, had passed through one of the Victorian public mental services in the preceding 1 year. 88% of them had made contact with public mental services in the last 6 weeks before they died. Quarter of them turned up to emergency department within the last 6 weeks. So what these numbers tells us is that if we were going to be serious about suicide prevention for borderline personality disorder, we need to somehow be able to identify the at-risk individuals with borderline personality disorder in the context of mental services and emergency departments, and try and provide appropriate psychological interventions. Another finding is that 95% of all people who died by suicide with a diagnosis of borderline personality disorder belong to the age group of 18 to 64. So it is the adult population that we need to focus on again. If this is for suicide prevention. Now, we also found that when you look at, so this is the busiest slide, I'm not going to go through that, but if you just look at the last 2 lines. So 80% of all BPD suicides were for the age group of 25 to 64, and 18 to 64 was 95%. Okay, now focusing on treatment of borderline personality disorder. As all of you are no doubt aware, there are no medications that are patented or indicated for treatment of borderline personality disorder. So it's period, there's no medications for borderline personality disorder yet. And the psychological treatments are the treatment of choice, and they're evidence-based. Comorbidity is the norm rather than exception when it comes to BPD. However, many psychiatric disorders that co-occur with borderline personality disorder don't respond to traditional treatments such as medicines as robustly as it would if they were not comorbid. What I mean by that, I'll give an example. Take the most common example of clinical depression. If someone has a borderline personality disorder and a diagnosis of clinical depression simultaneously, just trying to treat that clinical depression with medications or ECT, people are not going to, the response is going to be less than robust. However, if you treat the person with psychological treatment for BPD, not only the borderline personality disorder goes into remission, the depression also goes into remission, even without prescribing the medications. However, the most appropriate approach would be for such a patient to give an antidepressant for treatment of depression, expect only a partial response, and simultaneously provide psychological treatment for borderline personality disorder. And then you have the best chance of getting both those psychiatric disorders into remission. This seems to be true for other disorders as well, when they have psychosis co-occurring with BPD, or bipolar disorders co-occurring with BPD, or panic disorders and other disorders, and eating disorders. Now, BPD has been described as the king of comorbid kingdom. So, because the norm is to have co-occurring disorders, and it is not an exception. Only 5% of people with borderline personality disorder present in their pure form without any other co-occurring psychiatric disorders. So depression is most common, substance use 2/3 nearly, other personality disorders 90%, eating disorders again about 50 to 60%, and so on and so forth. The list goes on. Now, this is a list of all the evidence-based psychological treatments for borderline personality disorder. Right on top is dialectical behavior therapy, which is the most evidence-based, most researched, and the most common treatment. And next on the line is mentalization-based treatment, then schema-focused therapy, then transference-focused psychotherapy. The first four are called the big four treatments for borderline personality disorder, and they are the most common. Now, conversation model is the Australian contribution, and we at Spectrum have developed a treatment called the wise choices treatment based on the acceptance and commitment therapy. Now, this is a list of what we would like to call as the generalist treatments. There's something called structured clinical management, which is developed by Bateman, and general psychiatric management developed by Gunderson, good clinical care from Channon, a specific type of supportive psychotherapy, and an integrated treatment. See, all these treatments are much more easier to learn and less expensive to deliver, and they're not as they don't take as long as DBT or MBT to learn. Now, what we know is that see, all these treatments, they're all equally effective. There's nothing really much to choose between each other. And also, these treatments, generalist treatments, they are also equally effective. Now, the summary is that specialist treatments such as DBT and MBT work, but they're expensive. Generalist treatments such as structured clinical management, good clinical care, they're as good as specialist treatments, and that there are more commonalities than differences between specialist and generalist treatments and each other. So what it tells us is that you can blindly pick any one of those treatments, either specialist treatments or generalist treatments. They're all going to be equally effective. It's really not so much of a surprise. Okay, now there is further research which has happened where they've looked at they tried to look at what are the common factors, what are the juicy common factors in all those specialist treatments, like what is common in DBT, MBT, etc. Also, what are the things which are common in the generalist treatments? And also, they've examined all the international expert opinions of all the so-called experts and looked at the NHMRC clinical practice guidelines. Now, if you put all of this together, you can come up with a list of factors, which is already listed in the NHMRC clinical practice guidelines. Now, NHMRC clinical practice guidelines would make the statement that people with borderline personality disorder should be provided with structured psychological therapies that are specifically designed for borderline personality disorder and conducted by one or more adequately trained and supervised health professionals. Okay, this is really the summary of NHMRC guidelines. So remember, there's several components here. One, the treatment should be a structured psychological therapy, which has been specifically developed for borderline personality disorder. It can be a supportive psychotherapy, but it should be a supportive psychotherapy that has been specifically designed and developed, and it is structured. And it should be delivered by people who are trained to deliver those sort of treatments, and they should have access to supervision. Now, this is a slide which talks about the factors influencing outcome of any psychological therapy. I'm not talking about just therapies for borderline personality disorder. We know this in science, and we know that what are the most important factors which result in better outcomes for psychotherapy. We know that 30% of it is therapeutic alliance, therapeutic relationship, and the therapeutic technique contributes to only 15%. Patient expectations 15%, and the other factors, patient's personal support, strengths, etc., 40%. So what it tells us is that the therapeutic technique, the type of therapy, is actually less important. There are other factors which are much, much more important. So therefore, if we are really serious about making treatments accessible for every single patient with a borderline personality disorder in Australia, what do we need to do? We need to look at integrated, common factors-based, stepped care treatment that are adapted to Australian mental health systems. That's the way to go. Now, dialectical behavior therapy is fantastic. I'm a DBT clinician myself. Mentalization-based treatment is very good. They're all very effective. They're very useful. Now, are they the most appropriate treatments for the Australian mental health system? So that's question number one. And can they be delivered? Can they be made available to every single person in Australia? And does every single person in Australia with a BPD require that sort of a treatment? Now, I'll come back to that question in a while. This is a slide talking about the summary of all the outcome.
Sathya, I'm just thinking we've been on for about an hour. I'm just wondering whether people may like to have a 5 or 10 minute break. You're welcome to post some questions, but there's a little bit of a change in topic now, so this seems to be a good point to have a break.
Fantastic. So should we have a 10-minute break?
Yep.
So we'll come back at 3:10?
Yep. Thanks, Sathya.
Great, thank you. Just scroll through some of the questions in the chat box. Some of the slides should be able to cover those questions. If not, we can pick it up at the end.
Sure.
If you could kindly remind me if I have not covered them.
Yeah.
Okay, thank you for coming back. Now, let's discuss what is the prognosis and the outcome with or without treatment, or with non-specific treatments, and then look at some of the treatment strategies. Now, I have looked at all the 2 or 3 major long-term outcome studies And this is the summary of the two studies. The two major studies are you would know that Mary Zinnerini has been following up people with borderline personality disorder now for the 26th year of follow-up. And John Gunderson published a 10-year follow-up data. This is for patients who had severe borderline personality disorders. They had weekly contact and lots of lots of admissions, medications. So treatment as usual. They did not get any specific treatment such as dialectical behavior therapy or mentalization-based treatment or any of those generalist sort of treatments. Now, so this is the summary. 10% of patients went into remission within 6 months, 25% in 1 year, nearly half of them in 2 years' time, 85% went into remission in 10 years, and 60% of them recovered at 16 years. So there's a difference between remission and recovery. I'll explain to you soon. Now, the relapse rates, if you look at it, it is only 15%. You would know that the relapse rate for depression alone, major depressive disorder, recurrent depression, is 50%. Compare that with borderline personality disorder. So what it tells us is that it takes time to achieve remission in borderline personality disorder, but once remitted, the relapse rate is quite small. Of course, still severe and persistent impairment in social functioning is seen in 40% of the patients, even in long term. Now, most of the treatments that we have, the DBT, MBT, all of those treatments, they are treatments that helps us to work with patients to help them achieve remission, not recovery. So the recovery-focused treatments are now being developed. Okay. Now, remission in those studies are defined as people no longer meeting the criteria for DSM-5 criteria for BPD for 2 years or longer. Recovery is defined as having at least one emotionally sustaining relationship with a close friend or a life partner or a spouse, and be able to work, including work as a house person or go to school consistently, competently, and on a full-time basis. So full-time job and having a meaningful relationship. Now, this is again a slide summarizing the remission and recovery rates. So look at the remission rates. At 16 years, 99% of patients have achieved remission. Now, what happens to the outcomes when we do specialist treatment, such as DBT, MBT, or JPM? Again, 2/3 of the patients go into remission in 1 to 2 years. So what the specialist treatments do is they hasten remission and recovery. So if you do treatment as usual, still patients can improve, but it takes a long time. If you do specialist treatments, they hasten the remission and recovery rates. Now, I touched upon stepped care approach. So I'm not going to talk about this slide, but I'll pass on those slides to you and you can have a look at it. What it means is that, see, when we talk about treatment of borderline personality disorder, we talk as though everyone with a borderline personality disorder has the same degree of severity and complexity and require the same kind of treatment. Not true. So we know that people with borderline personality disorder can be classified into mild, moderate, severe in terms of severity, and each level of severity may respond to a different kind of intensity of treatment. Now, mild severity, whether they can be treated within the primary care setting, and whether psychoeducative approaches and brief psychological treatments could be utilized. For moderate severity of patients, whether it is the private system or the public system or the primary care system, where if you do the private system, most of the private system, at least in the Australian context, seems to do dialectical behavior therapy. But we are trying to encourage them to take up also the brave treatments and the common factors treatments. I'll talk to you a little later about what are common factors treatments. When it comes to severe borderline personality disorder, the public mental services need to treat these patients with common factors treatments or brief treatments or one of the four specialist treatments. So that's what we mean by a stepped approach. Of course, there are different ways of approaching the stepped approach. How are we managing borderline personality disorder in Australia now? There's still a significant stigma, and we don't have a population health approach. We have a very chaotic and fragmented approach. We often tend to manage only crisis, at least in the public systems. And we medicate them, we admit them to hospitals. There is limited access to evidence-based psychological treatments. Most BPD patients do not get adequate and appropriate treatments, and most services are not resourced to manage or treat people with borderline personality disorder. This is Professor Ian Hickey. He was the ambassador for the National BPD Awareness Week in 2017. And he makes a statement about borderline personality disorder. I'm not sure whether I can play the video and show it to you. I'll give it a go.
Hi, I'm Ian Hickey. I'm the co-director of the Brain and Mind Centre here at the University of Sydney, and I'm also a National Mental Health Commissioner. It's my great pleasure to support the awareness campaign for borderline personality disorder, BPD, and particularly to speak to those who are experiencing this condition and their families, and the ways in which we might more positively promote the quality of their lives and also more positive engagement with the health system. This has been one of the most challenging areas of modern mental health practice. People with BPD have frequently been excluded from reasonable care, not provided with real care and compassion, let alone adequate evidence-based treatment. And although they've often presented for care to emergency departments, to clinicians, to other parts of the health system, frequently been turned away, frequently been criticised, frequently been blamed for the problems that they actually present. I think very fortunately we now live in a more enlightened age, and we see real activism by people experiencing this condition, their families, and groups of clinicians who are prepared to support the journey that people with this condition need to undertake, and also to support very appropriately families and carers who are so affected by what is going on in this particular world. The Australian healthcare system has not been a great system in truth for the many people with mental health problems, but particularly for those with conditions like BPD who really require ongoing, specialised and sophisticated care on an outpatient basis, not largely in hospitals, largely in outpatient ambulatory care settings. We need to make sure that in the future we see the right responses in the Australian healthcare system, from clinicians, from local state services, for support under the Medicare system, but also in a broad community and particularly multidisciplinary forms of practice that really say we're here to help. Treatments are available. We can improve the quality of life for the person with the condition and provide greater support to their families. It's the time to be making those assertions right now. We have sympathetic governments, but we need to change the way we fund, support, train, and most importantly, provide the types of clinical practice that are likely to make a difference in the longer run. I look forward to seeing a real change in this area. For the last 30 years that I've been in practice, I must say this condition, BPD, has been one of the ones that's been most poorly treated, and where people who've had the condition and their families have been most excluded from reasonable care. I do think we're on the threshold of a significant change. So I welcome the opportunity to be associated with this awareness campaign, and I look forward to seeing the outcomes of this growth in community support.
Can you see this screen, Rita?
Yep.
Oh, good. Okay, just a couple of sentences about medications. Okay. Now, I was telling you that there are no medicines that are prescribed or patented or indicated for BPD. Having said that, medications are used extensively. We did a study in the Spectrum and found that half of the patients were on 5 medicines simultaneously. That's a bit scary. Now, if someone must use some medicines, this is the list. Quetiapine can be used in very small doses for short periods of time. Lamotrigine, topiramate can be used for periods of time, again, for specific symptoms. Aripiprazole is an antipsychotic, can be used. Fluvoxamine, an antidepressant. Before, in the past, we used to use a lot of antidepressants, but it's no longer indicated because the evidence is very poor. Again, now, if olanzapine is used, it should be used in very, very low doses, again for short periods of time for crisis management. This is one medicine I might prescribe more commonly, which is the fatty acids, the fish oil, the omega-3 fatty acid. This particular kind of combination of what we call as the EPA and DHA, those chemicals, that seems to be somewhat helpful because it's also harmless. One must remember that 25% of patients with borderline personality disorder tend to attempt suicide, not self-harm, suicide with prescribed medications. Therefore, needs to be very, very careful if they're prescribing medicines. Okay, now, can interested clinicians provide treatment? Whenever I talk about treatment in borderline personality disorder, I mean psychological treatment, of course. So can interested clinicians provide psychological treatment for borderline personality disorder if they are not trained in one of the specialist borderline personality disorder therapies, like such as BBT or MBT or schema focused therapy, one of those treatments? As you know, it takes years to learn those treatments, and you need to have proper resources to deliver those treatments in the way they are designed. So the question here is, if you're not learned one of those kind of treatments, can you still provide treatment for people with borderline personality disorder? So I wonder what you think. The answer is a resounding yes. This is again John Gunderson. John Gunderson, as I told you, is a guru of borderline personality disorder. He makes a statement that most clinicians can effectively treat most patients with borderline personality disorder. He also makes the statement that knowing that most clinicians can effectively treat most patients with borderline personality disorder should encourage mental health professionals to embrace the challenges that these patients undeniably pose. Only by doing this can they begin to address the public health needs of these patients. This is our senior clinical advisor, Associate Professor Josephine Bateson, my mentor. She makes a statement that effective psychological treatment for BPD can be provided by clinicians who lack specific training in psychotherapies. So she goes to extent of saying that you don't even need to have a specific training in psychotherapy, let alone a specialist psychotherapist. So you can still work with people with borderline personality disorder. Okay, I'll just go through a list of essential principles that we think are important if you're going to work with people with borderline personality disorder. First of all, one needs to sort out the diagnosis and tease out any comorbidities, like depression, bipolar disorder. If any of them are present or absent, that needs to be teased out. We need to make a good assessment of risks. Risk of self-injury, risk of suicide, and risk of any other aggression, anger, etc. Also understand why people with borderline personality disorder self-injure or self-harm. We need to. The straightforward way of doing it is to actually ask people with borderline personality disorder why they do it in a non-judgmental way. And most of the time they tell us. We need to develop a joint crisis management plan. See, often the crisis management plans fail because it is not developed in collaboration with the patients. See, of course, collaborative approach is something we want to do in every field of healthcare. But it becomes a particular focus in borderline personality disorder, and it is almost an essential component of treatment of borderline personality disorder. If you don't do a joint crisis plan, you really have very little buy-in from the patients. In our settings, we would actually give the template to the patient and actually ask them to fill it up, and in our presence, and we keep negotiating how that can be achieved. We need to provide good psychoeducation to the patients and the families. But what I mean by that is, of course, talk about the diagnosis, talk about the understanding of the etiology, talk about what the treatment is and how the treatment is going to be delivered and how long it's going to take for the treatments to work and what is the chances of treatments working. So all of that needs, and what's the role of hospitalization, medications, if that is considered. So all of that needs to be discussed with the patient and the family. Setting up a contract of care. So contract of care meaning how often can you see the patient and how much of time are you going to spend, and what happens if you go on holiday, and what happens if they go into a crisis. So all of that needs to be written down and signed off. In our practice, it need not be very, very elaborate. The initial contract can be just on a letterhead, handwritten, and it can keep developing over a period of time. To have a good contract, a good treatment plan, it may take even 6 months. But even from the first day, the first week, we could have a rough one-page treatment plan. Hospitalization needs to be avoided as much as possible, because what are we going to do in hospitals? Of course, see, if you don't know the patients, if they're new, of course, to make an assessment, we can hospitalize. Or there may be times when patients require a respite or others require a respite. Hospitalization may be useful for short periods of time. Or to treat comorbid conditions, hospitalization may be useful. Or when the risks are so high, short periods of time, hospitalization may be important. Otherwise, routine hospitalization is not going to help. And if medicines are used, it needs to be used very, very judiciously. Collaborative approach and having a consensus on how to achieve these goals. So how the treatment should happen, how frequently, what needs to be discussed, what kind of psychological work, all of that needs to be discussed with the patient and get the buy-in at the very beginning, if possible. We need to balance validation and change. See, there are some of us who feel so empathic towards the trauma or the developmental difficulties that patients have had. We can take an excessive validation only approach. That is good, but that is not going to bring about change. On the same token, if we keep trying to get our patients to change, learn skills and change without validation, that again is not going to work. So we need to find a fine balance of validation and change. See, and this is extremely well articulated in a dialectical behavior therapy context. But having said that, even in other treatments, they may not call it as validation and change, but the same concept is used in all evidence-based treatments for BPD. If you're going to work with borderline personality disorder patients, you need to teach skills. Skills to regulate emotions, skills to manage crisis, manage self-harm behaviors, manage interpersonal dynamics, and the skills to tolerate distress and psychological pain, etc., etc. It's very important to focus on emotions of patients and our own emotions. It is going to be inevitable that we are going to have emotional reactions, emotional experiences if you're going to work with people with borderline personality disorder. But we need to become aware of them and we need to work with that. We need to help our patients to connect their actions with their feelings and thoughts. Often we assume that they would have made those connections. They commonly don't. So it's important for us to help them connect their actions with their feelings and thoughts. We need to foster self-responsibility, self-agency, and treat them like adults, and not treat them as extremely fragile. Of course, we need to validate them and nurture them during periods of time when they require that. But by and large, the focus should be on fostering their self-responsibility. At the same time, I've had experiences where people have told patients that when patients say that, I'm going to kill myself, saying that, oh, it's your responsibility. That's what you want to do. You can do what you want. We can't really stop it. That's not fostering self-responsibility. We need to pay attention to the therapeutic relationship. Remember, I told you that the therapeutic relationship is the cornerstone for any psychological treatment, and especially treatment of borderline personality disorders. It's very important for us to establish a strong therapeutic alliance. Where possible, you need to seek supervision. And if you are working in situations where you don't have access or you can't afford to have supervision, a formal supervision, we can at least talk to our colleagues in a confidential manner. Because talking to colleagues who are going to be empathic, who are non-judgmental towards us, helps us to process our own emotions, feelings, and reactions. And emotions, feelings, and reactions are going to be inevitable if you're going to work with people with borderline personality disorder. So the evidence shows that clinicians who are trained, who are active in a therapeutic setting, who are willing, who want to actually work with borderline personality disorder, who hold hope, and who are enthusiastic, seem to do quite well with people with borderline personality disorder. That's research evidence. I think I told you that it is vital to educate, support, and involve family members and the carers in the treatment of BPD. And it is, again, it is crucial to encourage our patients to get a life. Get a life is a phrase used by Joel Paris, the Canadian expert. Because we don't want our patients to be, for their lives to revolve only around the treatment. So we want to encourage them to engage in occupation or studies and meaningful interpersonal relationships. There's some evidence that those two things can also contribute to further remission and recovery by themselves. So focus on functioning, it's important. Now, a couple of slides about risk management, because that is something which preoccupies us as clinicians very much. So what do you do? How do you really monitor risk? Because just the tick box approach of making risk assessment doesn't seem to help very much. So what we need to do is we need to look for changes in patterns of risk behaviors. Let's say we have a person with borderline personality disorder who superficially cuts most of the times. They cut, let's say, once a week on an average, about 4 to 5 times a month, and they cut superficially. That's the risk behavior they do. Now, if there's a change in that risk behavior, suddenly let's say that they start burning themselves or they start cutting themselves every single day, that's a change in the pattern. So look for changes in the pattern and become curious as to why they have had to change the pattern of self-harm behaviors. So it could be high lethal behaviors or low lethal behaviors. If they're high lethal behaviors, we need to be much more careful and much more carefully look for changes in the pattern. Now, understand the reasons for the change in the pattern, or if there is increased risk, try and understand the psychological dynamics and the emotional dynamics for the risk, and help them problem solve those emotional reasons. And if possible, remind them of the emotional regulation skills that you may have already taught them. And what we know is that if therapists are unable to tolerate suicidal behaviors, suicidality, suicidal thinking of people with borderline personality disorder, patients actually get more frightened. And that in itself can increase the risk. We need to discuss with patients what may help them towards risk management and validate their emotional pain and hopelessness of the situation from their point of view. I'm not trying to ask you to validate and encourage them to feel hopeless. But we need to make them understand that we understand their hopelessness, given the current situation they may be in, the way they understand the current situation, and help them to overcome that. And express hope and optimism, but don't become a cheerleader. Because if you become a cheerleader and express excessive hope and excessive optimism, patients can experience that as invalidation. Be aware of empathy fatigue, especially if you are seeing a high number of people with borderline personality disorder. And it is really a bad idea to get into a debate with patients that you are for life and they are for death. You are never going to win that argument. Having said that hospitalization should be avoided routinely, sometimes hospitalization can be life-saving. So we don't want to have a black and white rule about hospitalization. So we don't want to underreact. At the same time, we don't want to overreact towards risk. Involving family and friends and partners where possible is extremely useful in risk management. And consult colleagues, seek supervision, follow up closely. At the end of the day, the best possible risk management strategy that you can offer to people with borderline personality disorder is psychological treatment. If you do psychological treatment, that seems to reduce the risk quite significantly. Now, there were a couple of questions saying that if I'm a standalone therapist, what can I do? So if you use these treatment principles, so that would guide your work. Also at Spectrum, we have developed a list of core competencies. And we have also developed a training, entire 2-day training based on the core competencies program. In fact, this year we were going to go national and visit every state, including Tasmania, Northern Territory, and provide core competencies 2-day training. We have developed a manualized training. Unfortunately, because of the COVID situation, we are not able to travel, and we are hoping by end of this year or early next year, we'll be able to do so. So these are the list of core competencies that we have developed. So if anyone is going to work with borderline personality disorder, they need to have a comprehensive understanding of the diagnosis of BPD and the treatment of BPD. They need to understand the coexisting disorders. They need to understand the treatment principles. Some of those principles I just discussed today. Treatment structure. By that I mean having a good treatment plan, joint crisis plan, etc. And have the skills to develop a fine, positive, warm therapeutic relationship. And the clinician should also have the competency to teach skills development for regulating emotions, attention, distress tolerance. They need to have the skills to develop partnerships with families, partners, and carers. Working with risk. Again, skills development in some terms of sense of self, mentalizing relationships. Clinicians need to have self-awareness of their own thoughts, feelings, and emotions in relation to the work, and have a recovery focus. So these are the list of core competencies. Now, the take-home message from me is that any reasonable treatment provided by reasonable clinicians in a reasonable manner may be beneficial to people with borderline personality disorder. So this is a statement I borrowed from Mary Zanarini. Mary Zanarini is, as you know, she is the most eminent researcher in the field of borderline personality disorder. So as long as you don't judge, as long as you can try to validate the valid, as long as you can tolerate emotions, yours and theirs, and teach them skills to improve their quality of life, you can contribute to their recovery journey. So give it a go. So this is a list of key references for the slides. And as I told you, I'm going to share all the slides with you, and Rita will make it available to you in some form. And thank you. So Rita, I'm aware that someone asked me to discuss a case. So either I can take questions or discuss aspects of that case. I'll be guided by you.
I guess there's a couple of questions around what you feel area mental health services should offer in terms of treatment, and if there's any differences in what's going to be effective for adolescents.
Yep. So for the youth population, again, Andrew Channon from HYPE program, Origin Health, they have developed a cognitive analytic therapy, which is specifically developed and evidence-based for treatment of people, youngsters with borderline personality disorder. So that seems to be evidence-based. But again, dialectical behavior therapy has been shown to work for the youth population. And again, mentalization-based treatment again has some evidence. So again, it's the same principle as long as it is a treatment which is specifically developed for borderline personality disorder, and we take into consideration the developmental trajectory of the person, it can work. If you're looking for hard evidence, there's hard evidence for cognitive analytic therapy and dialectical behavior therapy. As I'm aware, also for mentalization-based treatment. Second question, what can be done in the context of mental health services? First of all, mental services can provide diagnosis, good diagnostic assessment, manage crisis of people with borderline personality disorder. And I told you that almost everybody in Victoria who have died by suicide with a diagnosis of borderline personality disorder have gone through mental services. So therefore, it is important to develop the skills to identify at-risk individuals with borderline personality disorder and provide them a treatment. Also support the primary sector, because most of the patients go through primary sector, and if mental services can support the primary sector, that goes a long way. Also the private sector. So in most of the states, if you're looking at where the majority of the treatment happens, whether it is the treatment as usual or evidence-based treatment, that seems to happen in the context of private system. Private psychologists and private psychiatrists and private allied health clinicians carry a huge load. So my experience, because I do a very small private practice, and my own experience, what I find is that when I want to access the help of public systems for my patients, it is near impossible. So if the public systems can actually support the private sector and the primary sector, that will go a long way in treating with people with borderline personality disorder. Also, the common factors approach. If we can teach all mental health clinicians in the public system core competencies and the treatment principles, and even if they provide short-term treatments, 6 months of treatment, or even 3 months of treatment, mental treatment, weekly psychological interventions using those common factors, that will be good enough. At Spectrum, we have developed a 10-session program, a 20-session program, a 80-hour group treatment that can be delivered in 10 weeks, or a 6 months treatment that can be delivered weekly, all using common factors approach. So any one of those approaches can be applicable in the context of public mental services. Public mental services have a huge role to play in the treatment of borderline personality disorder.
There's also a question here, Sathya, from a not-for-profit. And what advice would you offer to not-for-profits who have a with non-clinical services to respond to the needs of their clients with BPD?
I would again say that we discussed some of the treatment principles. Look, even if psychological therapy, office-based, like in a private psychiatry, private psychology, office-based kind of psychotherapy, even if that can't be done, I believe that we can be therapeutic in every single clinical interaction of ours. And that can go a long, long way in contributing to the recovery journey of people with borderline personality disorder. So learning to be therapeutic in every single interaction. So taking every single opportunity to validate, every single opportunity to teach them a small skill, every single opportunity to convey empathy, convey non-judgment, and helping them to connect what's happening in their behavior, and the mind.
Thank you. So question here, can you enlarge upon links with conduct disorder and BPD?
Look, there is if you, I don't know whether you noticed, one of the slides I put saying that borderline personality disorder comorbidity. I said that 90% of patients have other personality disorders. Okay, so if that's what it is, what it tells us is that, so are different personality disorders, are they very distinct categorical entities, or they all just one single entity? Now, if you look at ICD-11, maybe I should just show you the slides. Okay, I'll just. Okay. Now, this is the ICD-11 way of diagnosing personality disorder. In ICD-11, there is no categorical approach. By that, what I mean is that there's no different diagnosis of BPD or antisocial personality disorder or narcissistic personality disorder, etc. You can make one single diagnosis, that is personality disorder. Okay, it's a unitary diagnosis of personality disorder. Of course, you can divide them into different severity, mild, moderate, severe. You can also say what trait is dominant, negative affectivity, detachment, etc. You can also, only category you can specify is a borderline pattern. This is where you can make a diagnosis of borderline personality disorder. So what it tells us is that the personality disorders are not very distinct entities. They seem to overlap with each other quite significantly. So from that point of view, childhood conduct disorder, it's been linked very strongly with adult antisocial personality disorder. But then adult antisocial personality disorder and borderline personality disorder, there's a lot of overlap. Now, in that sense, there is a link between conduct disorder and borderline personality disorder.
Thanks, Sathya. You mentioned step care.
Yep.
Just this person's wondering how the level of severity is defined.
Yeah, see, there is a Meritorious categorization of mild, moderate, severe. Also, ICD-11 makes that differentiation. One of the criteria which is used by Meritorious is number of admissions people have, severity of self-harm, frequency of self-harm, but it's not the best way of identifying severity, but it's an attempt. So if you're looking at those factors, I would suggest that looking at one, severity of the illness itself, which when I talk about illness, how many symptoms or how many criteria they have. So I said that only 5 criteria out of the 9 in DSM is required to make a diagnosis. There are a lot of patients who have all 9 criteria. So that is defined as more severe. Now, also complexity. Severity, complexity, and high risk. So these are the 3 things to consider.
Sure.
So I would suggest you to refer to ICD-11 as well as Meritorious work.
All right. Just one last one at the moment. So, Sathya, what are your thoughts on the development of peer workers and support within the BPD community, and such things as peer/mental DBT skills group? Not the full DBT, just the skills component, as a cost-effective way of helping more people, especially those that get turned away from state government mental health services as either not sick enough and do not have the financial means for any other therapy.
Look, peer workforce is extremely important, and that should clearly be part of the solution that we need to consider. If you're looking at a national approach, so I said that prevalence of personality disorder is 1%. If you look at it nationally, so we're going to have about 250,000 people with borderline personality disorder. Now, primary sector can help, private sector can help, public sector can help, and the peer workforce need to be integrated into all 3 sectors as much as possible. So peer workforce can go a long, long way in helping patients achieve recovery and remission. I'm fully supportive of that.
I'm aware that we've got about 5 minutes left to go. Is there any questions that people would like to ask?
Rita, before that, I just wanted to say that the person who gave the case, if the person wants to discuss that case with me, I'm happy to talk to the person one-on-one
Okay.
at some stage. And maybe you could collect the contact information, because I have prepared some slides for that, and I'm happy to talk to the person one-to-one.
I'm wondering whether you feel that information would be relevant. I've got some comments here. I'd like to hear the case. So maybe if you go ahead and present it, Sathya.
So it may take more than 5 minutes. And do we have the permission of the person to present the case?
I didn't specifically ask that question, but it was
Okay,
the offer was, maybe I'll stop recording. That might be the better idea.
Yep, if you stop recording, now, this is a 15-year-old female, long history of sexual abuse, severe neglect, very isolated, ongoing emotional abuse from her father. She has significant substance use issues, along with chronic suicidal ideation and self-harm. And she is currently treated within the context of a public mental health service, and child protection services are involved. The child protection services seems to investigate and then close, although they are aware of the risks. So the patient disengages from most workers due to not finding them helpful. There is a chronic pattern of feeling like care provided is not good enough, and that no one understands how difficult her life is. That's the patient's perspective. She has highly abused. She's been highly abusive towards her mental health workers for 4 months now, due to being angry when they had to call the police for a welfare check after a suicide attempt. Now, the treating team is finding it very challenging to navigate her treatment in order to avoid colluding with an abandoning position or colluding with an abusive relational pattern. The team attempted to set limits around the verbal abuse and also attempted to repair the relationship for several months. But there has been no shift in the relationship. How to balance the need to set appropriate limits and to avoid iatrogenic harm associated with continuing treatment, with also wanting to model distress tolerance and support repair. Quite a complex situation. I'll raise a few questions around this case, given the limited time. Otherwise, I was going to do a workshop-y kind of a thing. Now, when you think of, park that case for a moment. When you think of a person, if you just add this information with you, 15-year-old woman, sexual abuse and emotional abuse, severe neglect, ongoing emotional abuse by a father, and frequent involvement of child protection services. If you add only this information, what are the behaviors that we would expect as clinicians from this woman? Just think about it for a moment. Now, we would expect trauma-related behaviors. We would expect attachment disorder-related behaviors. We would assume that this woman would have attachment disorders. She's going to have very poor social and interpersonal skills. So she is also going to have age-appropriate adolescent behaviors. And all of these things, all these four, are going to influence and intersect with each other, and leading to complexity. And on top of that, if you also add substance use, so then substance seeking behaviors and substance use related behaviors would also factor in. Now, we would expect the person to use avoidance, given that she's been traumatized and abused. She would have impulsivity, self-harm can be expected, emotional lability, and she's not going to place trust on most people, most adults, because adults have abused her and traumatized her and neglected her. She's likely to have a degree of narcissism, and this is protective. Narcissism will be protected because no one else loves her and she needs to love herself. She's going to have poor engagement. Some of the poor engagement is going to be age appropriate. 15-year-old, how many 15-year-olds we know would engage in treatment? I use the word manipulation because if I was in her shoes, I would want to manipulate the system to my benefit. And of course, substance use could be expected. She is also going to have significant self-loathing. She's going to be angry and she's going to be abusive. So that's the pattern we would expect. We imagine someone with this sort of problems. Now, what are the qualities, human attributes that patient is likely to appreciate in others? Any human being, and of course, clinicians. Okay, given that history, we would expect that she would want someone who can build trust, confidentiality, empathy, flexibility, unconditional positive regard, warmth, patience, validation, etc. So here in this patient, she believes that the trust has been breached because we call the police. So she of course she's also 15-year-old and she doesn't trust adults. So that part of it requires repair. So I would probably ask her a question as to what do you think we should be doing or we should have done in those kind of circumstances? And we need to get into some conversation about it. And I would say I apologize for the hurt that has caused for you, and I apologize for the breach of trust. At the same time, I would say that I had conflicting values. One is to make sure that you're alive and safe. At the same time, I didn't want to breach my trust and confidentiality. I was trying to balance these two, and this is what I went for. What do you think I should do next time? What do you think I should do if I feel that you're suicidal next time? And we need to, that's where the treatment plan and the joint crisis plan comes into a picture. So she would also expect the human attribute of nurturance, care, non-judgmental attitude, etc., etc. I'm sure the clinicians at your service have looked at all of this. If she doesn't find what clinicians have offered so far as useful, repeatedly disengages, how would you manage it? So we need to find out whether what we have offered so far, if she's not felt it as useful, we need to start with that baseline, that she's not finding what we offer as useful. So what should we do according to her that would be useful for her? We may not agree with that, but we may have to go with that for the time being until we have established more trust and therapeutic relationship. So also we need to look at the review the therapist clinician approaches. Remember this list I gave you, whether we have done all these things or not. It can be hard, and seek supervision for the team and clinicians. Without knowing the more details about the case, this is the best answer I could come up with. The last one, how to balance the need of to set appropriate limits and avoid iatrogenic harm. Balancing our limits and change. So not taking your verbal abuse personally. That is what I meant by being non-reactive emotionally, and tolerating her emotions and our emotions. Seeking supervision, helping her understand the impact it has on clinicians. So I would sit down and tell her, what do you think is the impact on the clinicians when you actually get so angry with them? Making her mentalize, understand. And also teaching her alternative communication skills. So teaching her emotional regulation skills, because she's angry, that's why she's abusive. We expect her to have emotional dysregulation. So, and also collaboratively working with her, the consequences of her abusive behavior. That's where you limit that in the context of a joint plan, but that needs to be done collaboratively. Once you develop that and she signs off and then sign off where appropriate, implement the plan, and she's obviously not going to follow the plan, review the plan constantly. So that